Greetings from New Delhi. Welcome to the monthly Journal Club of Association of Spine Surgeons of India. At the outset, I would like to thank ASSI for giving me this opportunity to present preoperative planning for kyphotic deformity correction in ankylosing spondylitis. Myself, Dr. Gururaj Sangondimath, Senior Consultant and Unit Head at Indian Spinal Injury Center, New Delhi. I'm going to take you through today the preoperative planning of deformity correction in ankylosing spondylitis. I'm also a Community Development Officer of AO Spine Indian Subcontinent, member of Education Committee, Association of Spine Surgeons of India, and ex-executive committee member of ASSI. So we all know that ankylosing spondylitis patients can present with very gross deformities like this, where they lose completely to able to stand straight and walk straight. So the deformity can be really gross and grotesque. So it needs a proper preoperative planning to correct these deformities to achieve a proper standing and walking. So what deformities do they present with? They have flattening or kyphosis of lumbar spine. There is a thoracic hyperkyphosis. There can be cervicothoracic kyphosis, or there can be maintained lordosis at cervical spine, depending upon whether the cervical spine is ankylosed or not. There also can be flexion deformity of the hip and knee because of the involvement of these joints. What are the consequences of this deformity? Loss of frontal gaze. They are not able to see straight. Restricted mobility because they cannot stand or walk in an erect position. Because of this, flexed posture causes a lot of strain on muscles. They get easily fatigued, and they also experience activity-related pain due to easy fatigability. With the gross deformities, they can have abdominal organ compression and respiratory insufficiency because of the costopelvic impingement. When it comes to deformity evaluation, we have to evaluate them clinically and radiologically. You almost always need a 36-inch long film, standing film, which covers the whole spine from C2 down to femur, proximal portion of the femur. The type of deformity can be round, it can be angular, or it can be both. When it comes to indications of surgery in these patients, the indications of surgery are progressive kyphotic deformity, increasing axial pain, neurological deficits, even though it is rare, abnormal gaze when they are not able to see straight and do their normal daily routine activities, difficulty in breathing because of severe kyphosis with costopelvic impingement, and impairment in daily routine activities because of above mentioned problems. So what do we want to achieve in a surgery? So we want to arrest the curve progression, correct the curve, give pain relief, and improved function. So these all things can be achieved by achieving a stable and balanced spine. So again, the aims of deformity correction in AS in terms of a balanced spine are to achieve an optimal spinal alignment, to get a center of gravity of the trunk to be brought over the hip axis, to maintain pelvis hip in neutral position. What I mean is, when a center of gravity of the trunk comes over the hip axis, your pelvis, hip, and knee has to be in neutral position. They shouldn't be in a compensated position. And foremost important thing is to achieve optimal chin-brow vertical angle. So to achieve all these, we need to do osteotomies. So there is a lot of confusion. Which level osteotomy has to be done? Whether we do single or multiple level osteotomies? When we do multiple level osteotomies, whether we do skip osteotomies or a contiguous osteotomies, and when do we do osteotomies, what are the proximal and distal levels of fixation? So in all these, the first and foremost thing is pre-operative planning of these osteotomies. So which is complicated because of this confusion, because only calculating angle of correction will not suffice. The level of osteotomy also matters, and it in turn decides your sagittal balance and correction of chin-brow vertical angle. So when we have to balance both correction angle and the level of osteotomy, it creates a lot of confusion, and it needs proper preoperative planning to achieve a proper balance. So when it comes to history of preoperative planning of these deformities, initially they were done on the templates made on the X-ray films and some mathematical formulas. But as the science advanced, Von Royen BJ in 2000, they came up with the mathematical calculation for osteotomies. And then in 2006, Ondra SL et al. Simplified these mathematical calculations based on tangent formulas. And then in 2006, Kim et al. And Bridwell et al., they again came up with the simple formula of calculating the harmonious balance between thoracic kyphosis and lumbar lordosis, saying that lumbar lordosis has to be 20 degrees more than thoracic kyphosis. If we can achieve that, we can achieve a balanced spine. But they ignored completely the pelvic parameters. Again, Rose and Bridwell et al., they again came up with another harmonious calculation, saying that now they included pelvic incident into their calculation, and they said that the thoracic kyphosis plus pelvic incidence plus lumbar lordosis has to be less than 45 degrees to achieve a harmonious curve or a balanced spine. But then again, this was not individualized. We know that there can be different kinds of pelvis according to Rosoli's classification. So it needed some other modification. Then Schwab et al. Came up with this calculation that PI is equal to lumbar lordosis plus or minus 9 degrees. If we can achieve that, the spine will be balanced onto the pelvis. But this again ignored another factors like a knee flexion, which is compensatory mechanism in ankylosing spondylitis. So that is why Liu Hook et al. In 2011 came up with this full balance integrated technique where they considered spinal balance, pelvic balance, and the femoral obliquity angle or a knee flexion, which is compensatory mechanism to achieve a proper balance in a straight standing position. In 2013, Song et al., again, they came up with a new method of calculating exact required spinal osteotomy based on positioning the center of gravity, that is truncal center of gravity, onto the hip axis. So why all these calculations, why all these methods came up all these years? Why there is no one simple mechanism? That is because the ankylosed spine behaves in a different way. It needs a proper calculation to achieve a balanced spine. So further in our presentation, we will see these three main groups of people who did a lot of study on preoperative planning of ankylosing spondylitis deformity corrections. We'll start with this paper, which was in 2000 by B.J. Von Royen et al. So they did multiple studies, and in subsequently they published multiple studies. They also came up with a proper planning software after their results. So their this preoperative planning was totally based on this um, principle that when an ankylosing spondylitis patient tries to correct his chin-brow-vertical angle to have a horizontal gauge, he compensates initially by retroverting the pelvis, which decreases the sacral slope or a sacral end plate angle, and then he extends the hip. When these compensatory mechanisms are not able to correct the chin-brow-vertical angle, he corrects by flexing at the knee and flexing at the ankle. So their mainly calculations are based on this compensatory mechanism. So they based this on mathematical equations. They had 3 steps in this paper. One is biomechanical analysis. What did they do in biomechanical analysis? They did planning of osteotomy in this. And then they did some mathematical calculation based on normograms after digitizing the X-rays. They found out effect of the osteotomy, the degree of osteotomy and level of osteotomy on the sagittal balance of the spine. And then in third step, they tested their method on patients, 2 patients, and then they saw whether their calculations are going to be correct. So in biomechanical analysis, they took basically 3 angles. One is sacral end plate angle. That is a angulation of the sacral end plate to the horizontal. So normally it is 40 degrees, and in SCA the sacral end plate angle is reduced because of the retroversion of the pelvis. So they wanted to know what is the basically the corrected sacral end plate angle. And then they also saw sagittal vertical axis. That's the horizontal distance between the posterior edge of the sacral end plate and the plumb line drawn from the C7 inferior end plate. And then the third measurement they did was a chin-brow vertical angle. The chin-brow vertical angle correction needed to achieve a horizontal gauge was assessed by in 2 positions. First, when a patient stood with the knees and hips in a neutral position, the chin-brow vertical angle was measured, and then the patient was encouraged to flex his knees, extend his hips to correct the chin-brow vertical angle to achieve as much as possible horizontal gauge, and then the CBVA was measured in that position. The difference between these two was taken as a correction angle required to correct the chin-brow vertical angle to achieve a horizontal gauge. And the total correction angle was the difference in the basically the deviation from the sacral end plate angle from the 40. If it would have been 20, then 20 is added to the correction CBVA correction angle, and the total correction angle was calculated according to that. If we take CBVA correction angle as 20 and the deviation from SCVA from 40 is 20, then the correction angle required was around 40 degrees. So you have to achieve a 40-degree correction from your osteotomies. But then we all know that only the correction angle doesn't matter. The level of osteotomy also matters in correction of the CSVA to the normal to achieve a balanced spine where the C7 plumb lines falls onto the posterior superior corner of the S1. So that is why they formed normograms and did mathematical calculations, complex mathematical calculations, and came to they saw that effect of these corrective angles and level of osteotomy, which level of osteotomy will give us a proper correction of C7 plumb line. But because of these complicated mathematical calculations and normograms, this method became practically difficult to use in day-to-day clinical practice. But then in results, they saw the effect of spinal osteotomy on the horizontal position of the SVA depends on the combination of correction angle and level of osteotomy. So they also saw that smaller correction angle is required if lower spinal osteotomy is performed. So the principle of correcting lower on the lumbar spine to have a better SVA correction started from these normograms. But then this method had a limitation because this method didn't individualize its calculation because they took SCA as a fixed angle of 40. We all know that the SCA or a sacral slope can be different in different individuals. So we need to individualize it. And the mathematical formulas promoted were complicated and were difficult to be used in daily practice. So we needed some different method or a better method where we can use it in a daily practice. So that is why they came up with this software where basically they tried to compensate their complicated mathematical formulas by automatically allowing to visualize the planning procedure on sagittal plane corrective osteotomies of the spine in ankylosing spondylitis by this software. So, but still this didn't take up, this was not very much practically possible. So in 2011, Lee Hook came up with this new method of called full balance integrated technique, where they based on their principle that the pelvic parameters has to be recovered to the initial shape of the spine before spine went into imbalance. So we need to achieve the normal pelvic parameters, and paying attention to the pelvic and spinal parameters in accordance with the Rasuli's classification gives us a better spinal balance. That was the principle where they based on their calculation. So they also based on, they added one more angle based on femoral obliquity angle. That is the equal to the knee flexion, which is there as a compensatory mechanism to achieve a basically a balanced spine or a corrected chin-brow vertical angle. So they showed that when we do osteotomy without considering this flexion deformity or flexion at the knee or a femoral obliquity angle, when the patient stand in post-operative period with the knee straightened, knee extended, the spine goes into again positive sagittal balance. So if we factor in this femoral obliquity angle or a knee flexion, then the correction will be better and we can achieve a spine in a balanced position with knee completely extended. So for this, they did a basically retrospective study on 10 years of their cases, 18 patients of the retrospective patients, and they tried this method on those patients, and then prospectively they tried on 8 patients this method of full balance integrated, and then they came up with their results. So for this, you need a full spine X-ray, including spine from C1 to the femoral head and the first 10 centimeter of the femoral shaft. You need this full X-ray to basically calculate the correction angle according to this method. So the first angle to be calculated is angle of C7 translation. What do we mean by angle of C7 translation? That is basically when you want to have a good spinal balance, where you want to transpose this point A, that is C7 at a original position, into a point B where it lies directly over the sacral plateau. So when you transpose this point from A to B, so you draw a line from A to a point, reference point on the osteotomy level. If you're doing osteotomy at L4, then at L4. If you're doing osteotomy at L3, then at L3. And a reference point is taken at the anterior margin of the L4 or L3, and midpoint of that point is called as point C. So these 3 points A, C, B form a triangle. The angle formed by these 3 points is called as angle of C7 translation. In this method, they usually took L4 as a osteotomy level because we have found that more distal the level of osteotomy, with the lesser angle of correction, we can transpose the C7 back onto S1 plateau better. And they also said that doing L4 osteotomy corrects your pelvic tilt better. So that is why they took a reference point on L4. And then angle of femoral obliquity. Angle of femoral obliquity was measured with the vertical, and this angle was added to the C7 translational angle. And this femoral obliquity angle is equal to knee flexion angle. And then the third angle is angle of tilt compensation. It was decided that if the PT measured on standing X-rays was less than 25 or more than 25, 5 degrees added to the correction angle, C7 translational angle, and femoral obliquity angle if the PT is less than 25, and 10 degrees is added if it is more than 25. This is based on Rasuli's classification of the pelvis. So the total angle of calculation or angle of correction is C7TA, that is C7 translation angle plus femoral obliquity angle plus pelvic tilt correction angle. So if you achieve this angle of correction, then you can have a balanced spine. So they included all kinds of kyphotic deformities except the post-traumatic angular kyphotic deformities. In first group A, they had retrospective group, that is 18 patients, and second group, they had prospective group in 88 patients. And their results showed that both groups showed that FBA technique was correct approximation of amount of correction needed in order to obtain C7 plumb line passing through the S1 plateau. They also saw that in retrospective group A, there was insufficient correction because calculation did not include the femoral obliquity and the tilt compensation. So that is why the angle corrected was less and they had a insufficient correction. So they said if you include the C7 translation angle, femoral obliquity angle, and pelvic tilt correction angle, then you will achieve a better balanced spine. But the limitation in this study was the numbers were less and the maximum patients were in the retrospective group. And coming to ankylosing spondylitis patients, there were only 4 patients, 1 in retrospective group and 3 in prospective group. And they selected all kind of patients in this study to test their calculation method. And this calculation doesn't take into consideration if there is a cervical ankylosis and if there is a deformity at cervical level, and they doesn't consider chin bro vertical angle, fixed chin bro vertical angle. So to improve on this or to calculate it in a better way, in 2013, Song et al. Published this study in Spine, and they were from Chinese People Liberation Army's General Hospital from Beijing. A new method for calculating exact angle required for spinal osteotomy in ankylosing spondylitis. So their principle was based on the ideal method for maintaining sagittal balance is to shift the center of gravity of the trunk. Now they didn't take the C7 as the balance parameter. They took a center of gravity of the trunk, which they had hypothesized and they had showed that hilus of pulmonis, that is hilus of left lung, corresponds to the center of gravity of the trunk in their previous studies. They took as that as the reference point. And to balance this center of gravity onto the lower extremity joints, that is hip axis. So their principle was based on getting this hilus of pulmonis or a central gravity of trunk on the hip axis. So they did this study from May 2009 to 2011. 20 patients with ankylosing spondylitis deformities. This was a prospective study. And they did pre and post-operative full-length spine radiographs and measured all the spinal and pelvic parameters in terms of thoracic kyphosis, lumbar lordosis, and they also measured COP from T1 to S1, pelvic incidence, pelvic tilt, sacral slope, and sagittal vertical axis. But then they excluded patients in this study, they excluded patients with kyphosis of COP T1 to S1 more than 90, because they said that in these patients, you have to achieve as much as correction as possible to achieve a balanced spine when COPS angle is more than T1 to S1. So to calculating an exact angle will really doesn't matter in these patients. So what is hilus pulmonis plumb line? So the hilus pulmonis plumb line is the corresponding reference point for the center gravity of the upper trunk. So this point was corresponding to the center of gravity, which they proved in their previous studies. And they saw where the hilus of pulmonis is lying in pre and post-operative X-rays. And then they also calculated post-operative individual PT, which was defined by a basically pre-operative pelvic incidence. So they calculated theoretical ideal pelvic tilt for that individual based upon the pelvic incidence in the pre-op X-rays. So they calculated PT based on this formula, that is 0.37 multiplied by pelvic incidence minus 7 degrees is a theoretical PT which we should achieve in a post-operative X-rays to achieve this hilus pulmonis HP lying onto the hip axis. So this is a method they adopted. So if we see in this first, that is A, if you want to do the osteotomy at this L2 level, where there is already a 10 degree of kyphosis, and if you have a PI of 38 degrees, that's the hip axis, center of the femoral heads. If you want to achieve a hilus pulmonis, that is HP, that is which is here, is to lie on exactly your HA, and with the balanced spine, you have to achieve a theoretical PT of 6 degrees according to the calculation by the formula based on pelvic incidence. So when you do that, you draw a line which is called as theoretical PT SVA, measuring a 6 degree of calculation angle, and then which goes like that. And then when you want to correct, so you have to take a reference point onto the anterior margin at the midpoint. From there, this is called reference point at the osteotomy level. From there, you will draw a line to the hilus pulmonis, and the distance is taken as a radius, and then you will draw a circle there. The circle will intersect this PTC SVA at point HP1, where the hilus pulmonis should lie to have a balanced spine. So the angle sustained by this 3 points is the correction angle. So if you see here, they have achieved a 40 degree of lordosis at L2, and with the addition of 10 degree kyphosis, they have achieved a 50 degree correction where the hilus pulmonis is directly lying on the hip axis with the proper spinopelvic balance. So their method was based on this corrective angle. But they also, with this calculation, they saw that all patients demonstrated changes in preoperative to postoperative radiological parameters, including they had a decreased PT from 30 degrees to 11 degrees and SVA from 18 centimeter to 7 centimeter and increased sacral slope from 16 to 35 degrees. So, but then the limitation of these studies, they excluded severe deformities where the SVA or the cob was very, very gross, and it cannot be used. This method cannot be used when the cervical spine is used. So what needs to be done? So they came up with this next study in 2016. It was published in Spine with the same group, where you needed a more correction, where the deformity was more pronounced. So they came up with this paper on how to calculate the exact angle when you have to do 2-level osteotomies in ankylosing spondylitis. Again, this method was principally based on the same method as previously calculated. They said that the 2-level osteotomy is required to correct both the compensation of the lumbar flattening and thoracolumbar kyphosis, and to have a harmonious correction. If you do all the correction in the lumbar level, the apex of the lumbar lordosis changes and causes a lot of stress on the implant. So if you want to have a harmonious correction and want to correct the thoracolumbar kyphosis, junctional kyphosis also, you need to have 2-level osteotomy. So their method was calculated on this. For example, in this patient, if you want to do an osteotomy at L2 and D12, which has a kyphosis of minus 11 degrees and 17 degrees and PI of 51 degrees. With this formula, for this individual, the PT has to be 12 degrees. So in the same way, what we did in previously, draw a SVA of corrected PT from hip axis measuring around 12 degrees, and then you will take 2 reference points on the anterior surface of D12 and L3. In this case, it's L3, and then it is marked as RPL3 and RPL1. And then now, considering the distance between RPL3 to RPL1, you will draw a circle, and then you measure the kyphosis correction. If you want to do a 45-degree kyphosis, so you draw anti-clockwise. You go and draw a line for 45 degrees intersecting the circle. So the next step is, from this point O where the circle has intersected this line, you will draw a line with the radius between RPL1 to HP, a circle with the center at O, and then connect this O to the point where the hilus pulmonis should lie. So this total angle of correction is 80 degrees. So if you want to achieve a harmonious, well-balanced spine, you have to deduct this 45-degree angle correction from this 80 degrees and to have a 35-degree correction at D12 or a L1. So if you see in this post-operative X-ray, they achieved 18 degrees of lordosis, that is including 17 degrees of preoperative kyphosis, that's 35 degrees. And there was 11 degree of kyphosis with the 34 degree of lordosis. You can achieve a well-balanced spine where center of gravity of the trunk is exactly lying on the hip axis. So if you see in this, if you calculate only one osteotomy in the same patient with the pelvic incidence of 40 and a theoretical PT of 8 degrees, the correction angle required at L2 will be 60, at L1 will be 72, at T12 will be 85. So this also proves that as you move downwards into the spine, the correction angle required will be lesser and lesser. But then if you want to do a 2-level osteotomy, then you will have to do a greater degree of correction, that is around 65 degrees of correction. And you can do a 45-degree correction at L2 and remaining 20-degree correction at T12. The same way, if you choose to do a 30-degree correction at L2, if there is no preoperative kyphosis at that level, then you might have to do a 40-degree correction at T12 to achieve a balanced spine. But then all these formulas don't apply when it comes to ankylosed cervical spine. So there, the calculation has to be different. With the Suk et al. Studies, we have known that patients have best results when the chin-brow vertical angle was in between 10 degrees to 20 degrees. So it is well accepted to perform a lesser degree of osteotomy angle to ensure that patient has a horizontal visual field rather than patient looking up. Or if at all you want to have a balanced spinopelvic balance, then you might have to do a flexion osteotomy at the cervical spine if you want to achieve full correction. And the formula for osteotomy angle when the cervical spine is fused is the correction angle should be chin-brow vertical angle plus the existing PT minus the theoretical PT. So we know this formula, how to calculate this theoretical PT. So this was given by, again, Songs et al. So in summary, deformity correction in ankylosing spondylitis is complicated, needs proper preoperative planning, considering all the spinopelvic parameters to achieve good results. FBI method and Song's corrected PT method are more reliable. Major sagittal imbalance will need 2-level osteotomies or more. In an ankylosed cervical spine, under correction has to be done. Otherwise, you might have to do a flexion osteotomy at cervicothoracic junction. Thank you.